Hello, my name is Stephanie Tan from the Institutional Development Team at Bursa Malaysia. First and foremost, I wish to thank all of you for taking the time to join us today. This event is jointly organized by Bursa Malaysia and AmInvestment Bank Berhad, and the focus area would be on virology, in particular, the coronavirus' unique characteristics and its implication in the scientific community's search for an effective vaccine. We will also explore some of the key challenges in the management of infectious diseases and the efficacy of the country's infrastructure support and policies development and enforcement requirements. So I would like to thank Dato Professor Dr. Adeeba Kamarulzaman, who is trained as an infectious diseases physician and is currently the Dean Faculty of Medicine, University Malaya, Adjunct Associate Professor of Yale University, President of International AIDS Society, and member of the UN AIDS Advisory Group, for agreeing to be our guest speaker today. Today's session is timely given the recent welcome news development on a promising vaccine developed by Pfizer and BioNTech. The coronavirus pandemic has wreaked tremendous strain on the healthcare system, supply chain, global economic output, and the general public well-being internationally, and Malaysia is no exception. So we have invited Professor Adeeba to give her assessment of the third wave currently facing Malaysia, as well as share her thoughts on the lessons learned from the healthcare response globally and locally that will prepare us for the challenges that lie ahead. There will be a question and answer session after her presentation, moderated by Shadida Ibrahim and Joshua Ng from the Equity Sales and Research Departments of AmInvestment Bank Berhad. We encourage you to share your thoughts by participating in the discussion. A quick reminder for all of you is to please mute your microphones when Professor Adeeba is giving her presentation. So without further ado, it gives me great pleasure to invite Professor Adeeba to start her presentation. So over to you, Professor Adeeba.
Thank you very much, Stephanie, and thank you, Bursa Malaysia and AmInvestment Bank for inviting me this afternoon. Certainly, we have all lived with this virus now for the last 11 months. And the first thing I want to say is we're going to have to learn to live with it for quite a while yet, although we've all heard of the exciting results from the Pfizer vaccine yesterday. What I intend to do in the next half hour or so is perhaps, kind of share with you what I think, what we now know about the virus, what are some of the things that a lot of things that we still don't know, and in order for us all to, as individuals as well as societies, to learn to live with this virus for the next many years until that promising vaccine does get to us, does get injected into us, and we're all immune against this virus. So let me recap very quickly for those of you who've not been to this website. This is an amazing Johns Hopkins website that updates many things, including the number of cases and the number of deaths globally. So, it's since January, we now have all over the world 50.5 million cases with 1.2 million deaths. You can see the red spots across the world. Many countries have been hard hit, including the US, as you know. Parts of Europe, India has done particularly badly. And what is good is that I think we in the Far East has really led the world in terms of the response, from Taiwan to China itself, Vietnam, Thailand, Singapore, Australia, New Zealand, of course, have all been the shining lights in terms of a effective response to the virus. And that includes us, Malaysia, as well, particularly in the early parts of the pandemic. We're not doing so good at the moment, but really, I don't think we're doing so badly either. Of course, we don't want to compare ourselves with the US and Europe, but this is as of yesterday. If you look at it, the hot zones still remains Sabah, but the numbers that are increasing, I think in Negeri Sembilan is is one area that we need to watch. The cases in Selangor and KL, of course, if you look at the number of new cases in absolute terms, it's a worry. But when you put it against the size of the population, then really and you've probably heard that there are other epidemiologists who are questioning in terms of, is it really, do we really need to hit the panic buttons with these kinds of numbers, given the population density, given the pace at which the numbers are increasing. The other thing that we've learned since February, March is about the disease itself. Certainly when we saw the CNN news about Wuhan, about Italy, about Spain, about France back in February, March, it generated a lot of fear, rightly so, because of the number of cases, the number of deaths, and because it was a new virus, nobody knew much about it. So the heightened anxiety, the need for lockdown and all that was very much justified, I think. But I think as a medical student, I was always taught, you treat the patients, not the numbers, especially when you're managing patients in ICU. And one can sort of apply to that here. Yes, the numbers are, we're seeing 1,000 cases a day, but or thereabouts. But in terms of the clinical disease, fortunately, the majority of the patients that we see, I'll share with you later on the breakdown. In terms of the severe disease, it's actually a small proportion of the number of cases that we are seeing, with the exception of Sabah. And the pattern in Sabah is actually quite different from the rest of Peninsular Malaysia, because the people there have trouble, first of all, the knowledge around the disease, the ability to get into healthcare, and so they present late, and so the disease is able to spread. And also we are seeing more ICU admissions and more deaths in Sabah precisely for those reasons. So in Peninsula, so overall nationally, we have, as of yesterday, 86 people in ICU and 31 people needing ventilation. Now, if you remember back in January, February, one of the main reasons for countries instituting lockdowns is to enable the health system to cope. And with these numbers, thankfully, I think particularly in Peninsular Malaysia, we still have room, a lot of room to manage these patients. Now, that's not to say that we just don't do anything. I too don't subscribe to the Swedish herd immunity. Well, let everyone get infected. No, I think that's also a wrong approach. But somewhere in between, we need to kind of try and open up society as much as possible, whilst at the same time paying attention to trying to detect every patient who's infected through effective contact tracing and testing and quarantine. So I think that has to be the strategy, because that has to be the long-term strategy, because we can't afford to keep locking down, releasing. It's not going to do the economy or our own mental health any good. And I think based on what we're seeing with the numbers of cases of truly severe, significant disease, we can afford to do that. Although Stephanie introduced the talk as, I'm going to be talking about a lot of science of the virus, I actually will not, but I thought I will give some basic updates. I think all of you know probably nearly as much as I do, I think many people are now talking about R naughts and aerosols and transmission and all these scientific terms that were not so familiar just a year ago. So in terms of routes of transmission, I think what makes this virus really, really nasty in a way is because of its ease of infectivity, and the main culprit is really through this droplet spread and to some extent the aerosol spread, that every time you speak, every time you cough, there's millions of virions being released, and you can then inhale it if you're sitting on the opposite side, less than a meter. Or when it settles on surfaces and you touch it, and then you touch your eyes, your nose, or your mouth, you can then get infected yourself. Now, there's been quite a few new studies that also speak to that the virus can be transmitted a bit further through an aerosol spread. Because it can be airborne as well. And I think there is more and more evidence to that. What that means is, I think in terms of what we do, it again underlines the importance of wearing a mask and not being, and that physical distancing. Now, in terms of how important fomites or surfaces are, I think with the new science that's coming through, I personally think this airborne aerosol spread is actually a far more important route of transmission than the fomite itself, and the more attention needs to be given to ensuring that we all work in a well-ventilated office, outdoors. In terms of policies, going outdoor, spending as much time outdoors is better than being indoors, and things like that. The role that fomites or surfaces play, yes, it's still important, but perhaps as a mode of spread and the super spreading events that we see, it would seem that it has more to do with closed spaces and poor ventilation than it has to do with surfaces. So no, you don't need to wash your apples with Clorox anymore. I mean, you don't need to clean your. There was a time at the beginning of the epidemic, if I recall, that people would leave their newspapers and their letters out for 2 days to make sure that there was no SARS coronavirus on it. There were people who were madly washing their groceries when they came back from the supermarket. I don't think all that is necessary anymore, and then it just reflects the information that we had at the time. So now I think if you're going to be fussy about, I would say it would be wearing your masks and ensuring that if you have a meeting, open your doors. If you can open your windows, it's even better, because really where the likely outbreaks can happen is in closed spaces where there's lots of people with poor ventilation. So that's been quite a big leap in terms of understanding of the transmission of the virus, and with that, I think we can tailor our activities and our policies accordingly. I personally think not enough attention is being given to this, because moving forward, perhaps organizations and buildings can make some structural changes to their offices, because whilst COVID is bad, many global health people predict that this is not going to be the last virus that we have to combat. Now, this is a very scientific looking slide, just from this very well conducted study that looked at how long the virus lives on different surfaces, and basically it can last on plastics for a number of days, less so on copper surfaces. And so, you know, again, it tells you that the virus can live on surfaces, but at the same time, we know that the virus can be deactivated very, very easily with alcohol and soap and water, and hence the need to do, you know, to wash your hands, to clean your surfaces with Lysol and things like that. Okay. The other important thing is now we also have a very, very good understanding of the transmission from person to person. So I've just talked about the transmission from surfaces and transmission in the air, but what about this very confusing pre-symptomatic, asymptomatic, symptomatic definition? So what we know is that people who develop the infection, they can be infectious 2 days, at least 2 days before they develop symptoms. These are for people who then develop the classic symptoms of fever, of you know, losing their smell, losing their taste, and cough. So up to 2 or so days before that is when they can spread the virus to other people, and somewhere between 5 to 7 days after, some say 9, maybe let's stretch it to 9, that's the period for which people are most infectious. So the pre-symptomatic refers to the 2 days, 2 or so days where before you develop the symptoms, that however you can still pass the virus on to other people. And this came from a study from Singapore that showed that 6.4% of people who became infected in Singapore from a small cohort of 157 developed it from those who had no symptoms before they actually developed symptoms, and a similar study, a modeling study in China. What about the asymptomatic group? So we know now from huge cohort studies, initially in China and now in the US and in Europe, that 80% of people who develop, who become infected with SARS-CoV-2 or has COVID-19, about 40% truly don't have symptoms. So the range is from 6 to 41%. Let's say about 40% or so, you know, don't feel or don't have any symptoms. 80%, so that includes the 40% with no symptoms. So another 40% have mild disease like fever, some aches and pains, some cough, and so forth. And it's the other 20%, the 10% who get chest X-ray changes, pneumonia, needing some form of oxygen, and then the other 10% or so who get severe disease, needing more oxygen support, and about 5% or so needing ventilation. So in other words, about 20% or so of people will actually have significant disease, while the majority have either no symptoms or mild symptoms. If the rate of transmission from the pre-symptomatic people who eventually have symptoms but can transmit the infection before they develop symptoms is about 6.4%, it's felt that those who are truly asymptomatic, the likelihood of them passing the virus to other people is even smaller. It's from 0 to 2.2%. So it's mostly those who have symptoms that's more likely to pass the virus to you. So, you know, whilst we should be concerned about the asymptomatic, really, in reality, the likelihood of them passing the virus to other people is much, much smaller than those who get sick from the virus. And this makes sense because we know that viral load matters, which means the more virus you have in your nasal passages, in your trachea and lungs and so forth, the more likely you're going to pass to other people, and the more likely symptoms. So those are some of the basic concepts that we know so much more now than we did back in February and March. That also allows us to manage the disease, and both clinically and in a public health perspective. Now, a few other things that we've learned more in the last few months is how transmission in enclosed versus outdoor settings differ. So several studies in Japan, in Germany, in France, in South Korea, and more recently in India have shown the importance of these so-called super spreading events, where 1 or 2 persons can spread to, many other people. And in many of these situations, it's related to being in an enclosed space with lots of people, with in areas with poor ventilation. So some examples. The very first one was the lady who infected someone from in Germany, and she had gone to work in Wuhan and came back to her office. It wasn't in Berlin, but somewhere in Germany, Munich or something like that. And the cluster was from an indoor work meeting. Others showed, a chiropractic in the US, a church in South Korea, and in our own cluster in Malaysia was from, as you know, from the Tabligh cluster. And in Malaysia right now, if you look at the clusters, the majority, after we've successfully controlled the first wave in March from the Tabligh cluster, many of the clusters that we are trying to douse at the moment originated from either detention centers or prisons. Once again, going back to high risk areas that are enclosed, where there's a lot of people, where it's setting them up for super spreading events. So this is a really very well done study from China, which shows the importance of this closed environment and air ventilation and recirculated air and poor ventilation causing episodes of super spreading. So the index case is this person here, patient 0, and how he infected the rest of the people here, or because of this air conditioning that was recirculating air just amongst them here. All those people who were seated not very far away, but not within this this air circulation, were not infected. Neither were the waiters. None of the waiters or 68 other patrons at the remaining 15 tables became infected. So, so one of the conclusions from this is that long-range aerosol transmission can occur in any indoor space because of this recirculated air, especially when it's crowded and poorly ventilated. Now, the other good example of the importance of good air circulation is in aeroplanes. Actually, I can't think of a single report of clusters originating from flights with SARS-CoV. They may be, but the famous ones are the cabin crews, ships, but not aeroplanes. When you think of it, aeroplanes are very much closed space, but the air circulation in aeroplanes, because it goes through a HEPA filter, has been described as being virtually sterile because of the HEPA filter and the 50-50 outdoor air being circulated, as well as the rapid air exchange. So, the again goes to show the importance of air circulation and ventilation if we are thinking long term in how to manage this disease, whether it's in restaurants or whether it's in office buildings. So in summary, in terms of transmissions, crowded and closed spaces facilitate transmission. The longer you are in these sorts of places, obviously, the greater the risk. Airborne transmission is becoming more and more thought to play a role, but probably not, it's not going to change things greatly in terms of how we manage, how we wear, how the importance of masks. Now, I probably won't show you this, but I don't know if you want to take. These were two excellent interactive pieces in the New York Times. One shows you how the coronavirus is transmitted, and the other is the importance of wearing a mask. So we might not have enough time to show this, but if we do, I can go back because it would mean me logging off and logging on. We can do that later, but it's a beautiful illustration of the importance of physically distancing and how the particles can spread far and wide, and how the different types of masks can prevent infection and the importance of it. So in terms of how we learn to live through this pandemic in the next 24 months or so, I think, to be honest, we're not New Zealand, and going for a zero case is probably going to be unrealistic, because we have wide open borders in places like Sabah, in northern Malaysia, in Johor, and all along the peninsula with wide open borders. So totally eliminating the virus is going to be difficult and probably unrealistic, and would cause a lot of harm in terms of social harms, economic harms. That would be my opinion, because it would mean that we would almost have to be locked down forever, close our borders forever. What I think we would have to accept is a low level of infection where the hospitals can cope, and especially because we now have good medicine, even for those with moderate to severe disease, and I think that should be the strategy that we need to work towards, accepting a low level of infection, but at the same time being very, very vigilant for every new infection through effective contact tracing and quarantine and testing and so forth. I think a good investment would be in widening our contact tracing capabilities, giving more access to people, getting cheaper and quicker tests, rather than locking everybody up for many, many more weeks and months. Of course, it is not to say that we shouldn't have lockdowns. There might be times when we do need to, if there is a big outbreak. I mean, one can argue that maybe in many parts of Sabah that the MCOs will need to be continued for some time until we get good control of it. But in places where there's hardly any infection, really we should begin to open up and allow people to live as normal a life as possible. In particular, schools. I can talk about the importance of opening schools as well. So in New Zealand, they have been able to eliminate the virus because they responded rapidly. It was science-based, decisive. But I think equally importantly is the fact that they're an island, and when they close their borders, they can really, really close their borders. And so they've been extremely successful. But it's also important to note that there have been countries that have been equally successful that have not locked down at all, and that would be Taiwan. Taiwan, when you think of it, is next door to China, but as soon as they heard about the cases in China, even back in January, they went into, or they implemented their pandemic preparedness, which basically, got their labs organized, got their hospitals organized, their testing, their contact tracing, and they're very, very vigilant with their testing and contact tracing and quarantine, that they will check on people. If they say you are to quarantine for 14 days, you will quarantine for 14 days, and they will check on you electronically and with other measures. So Taiwan has, not locked down at all and have had very, very few cases and very few deaths. So there are different models and different examples of success. Vietnam is the same, and Kerala is another state in India where have also, through extensive testing and contact tracing, have managed to control the virus. So very quickly, in terms of what happens if you do get infected, as I said, 40% may have no symptoms at all, 40% mild disease, and the mild usually starts with very much like a flu or dengue, with fever and aches and pains, and cough and sore throat are common. And as it affects the lungs, in proportion of patients, you get shortness of breath and difficulty breathing. Who gets then you have there are a subset of people who get severe disease. It can affect the heart, it can affect the skin, nausea, vomiting, diarrhea. It can cause these unusual clots that can go to the lung, that can cause strokes. And all this, many of these unusual complications are actually due to the hyperactive immune response, otherwise known as a cytokine storm, where in the first week of infection, your body produces, the immune system tries to gain control of the virus, and your body produces all these proteins and cytokines called interleukins and tumor necrosis factors, etc., to try and dampen the infection. In the majority of people, they will recover within that 7 to 10 days, but in a subset of people, that immune response kind of goes haywire, kind of becomes hyperactive and overproduces, that leads to all these secondary complications. That's what's called the cytokine storm, and all the complications that we see. So these are the stages, the 5 different stages. Unfortunately, I'm showing you an old slide. I had an updated slide which shows admissions in Sungai Buloh Hospital. So in Sungai Buloh, from memory, I think less than 1%, this was as of October, less than 1% have critical illness. Severe illness was again about 10% or so. So the majority of patients are in this category, especially this first 2 category. Currently in Sungai Buloh, I think 60% are in these first 2 categories. I think 20% here, or 20 to 30% here, 10% and about 2 to 3% in this. The picture in Tawau looks a bit different. They have slightly more in these 3 categories, and like I said before, it is because of late presentation of patients, particularly living outside of Kota Kinabalu. So the other good thing that has happened since February, March is the knowledge around treatment, and because we understand much more how, what causes the symptoms, what causes the disease. So the first week to 10 days is a direct viral impact. The second week, as I said, is the immune response that goes into overdrive. we now know how to treat, and there have been many studies looking at different drugs. I think all of you are familiar with the hydroxychloroquine story that was trying to treat both of these, and that's been shown to not be effective. This drug remdesivir, it has shown to improve the symptoms, and to some extent some studies have shown it reduces mortality, but it's not sort of that game changer drug that everybody was looking for. What has been really promising is this dexamethasone drug, which is a very widely available, is part of the corticosteroid prednisolone family that we use in a lot of conditions, and many studies have shown that DEXA reduces disease severity as well. Large studies have shown how dexamethasone reduces disease severity as well as mortality. There's another very interesting class of drugs called the immune modulators. These are drugs that block these things like interleukin-6 and other cytokines. It's a group of drugs called the immunomodulators, and there are also a lot of studies studying these drugs. Again, hasn't been shown to be the game changer, but we at UMMC personally used it in a number of patients, and we saw very good results. So we are now involved in a study together with Sungai Buloh and Seremban Hospital and HKL to compare dexamethasone versus a drug called tocilizumab to see its impact in patients with severe disease, and to see the progression to needing ventilation. So I just literally got a message to say that we've enrolled our 11th patient into this study, but we will need to get up to 300 to see the benefits or otherwise of either dexamethasone versus tocilizumab. So of course, what everyone is waiting for are the vaccines. There are 91 vaccines in the preclinical stages or more, probably more than 91 plus. 28 vaccines are in phase 1 study, meaning testing for safety and dosage. Stage 2, phase 2, 14 studies have moved on for safety trials, and now 11 have entered into the large safety efficacy trials, and 5, including the one from Pfizer, the front runners, this Pfizer vaccine, the Moderna vaccine, and the Chinese Sinopharm Sinovac vaccine. So they are the front runners of in the vaccine development. Before we get too excited, this is very they're the different types of vaccine that's being developed. The one that Pfizer is developing is using the messenger RNA being put into a protein-based delivering protein, and it's 90, as you've all read, seems to be 90% efficacious, but in a very large trial involving 40,000 patients. However, the details of this study has yet to be released, so I think we're all waiting with bated breath, but certainly it's very welcome news. 90% effectiveness is certainly very promising. However, I think you've all also probably read that it's still going to be many steps yet, not least of which is in terms of scaling up production. I think Pfizer said they could only do like 20 million doses or something like that. So the Americans will say thank you very much. That leaves the rest of us, 8 billion people in the world, waiting. So the challenges in terms of getting vaccines to you and me are plenty. So we've only just, in terms of the Pfizer vaccine, we've only just maybe got somewhere here that we have a vaccine that's safe and effective in a large phase 3 clinical trials. After that, it still has to go through a series of reviews of efficacy and safety evidence. And third step would be countries would then have to decide based on national policies, based on ability to pay, and who to give these vaccines to. And of course, I'm going to be, if I'm advising, I'm going to say healthcare workers are the ones who, I'm joking, but really many countries are looking at healthcare workers, frontliners being the first people, and those at risk, elderly and people with comorbids. And then you have to manufacture them in large quantities. And then finally, how do you distribute them? It's going to be a complex process, and the Pfizer vaccine requires a cold chain. So that makes it challenging as well. So given those things, I think what is important is that we all, as individuals, will need to internalize what COVID-19 means to all of us as individuals, as co-workers, as community leaders. And it really is in a way quite simple. First of all, from what I've told you, crowded places, poorly ventilated, do I want to go there? Do I want to go to that wedding? Do I want to go to that office gathering where it's going to be in a tiny restaurant? Maybe not, okay? But if that wedding, that office gathering is in a wide open space, why not? Even if you're in a wide open space, I would maintain the distance. But if you're indoors, then definitely wear a mask. And if you're indoors, open your doors, open your windows, and really, as I said, very, very simple and doable messages that should really be part of how we live for the next 12 to 24 months. So I want to leave this presentation on that. And once again, thank you very much for inviting me, and very happy to take questions from any one of you.
I have two questions. First, what's the minimum limit of efficacy for a vaccine to work?
So, that first real promising vaccine, the Pfizer vaccine that we heard yesterday, well, they're claiming that of those people who received the vaccine, 90% responded. But what we don't know is how long the vaccine will last and how good the response was. So there are still many questions to be answered from this Pfizer vaccine.
I see. Okay, thank you. I beg your pardon. My name is Raza from AmInvestment. My second question is on vaccine is one thing. How about the medication to combat those who already
got infected?
Got it. Yeah. Is there any significant achievement in this arena?
Yeah, so I touched on it briefly just now. So there are many drugs that have been tried. So we know that hydroxychloroquine that Mr. Trump was championing doesn't work. There's a drug called remdesivir which works a little bit. I mean, it reduces the severity of the disease. Unfortunately, remdesivir is not available in Malaysia. It was available when we were participating in a clinical trial. However, the drug dexamethasone which, as I said, is a widely available drug, has been shown in a number of large studies to be effective to reduce disease severity as well as mortality. So that is the drug that we are currently using at the moment for those who show signs of deterioration. And there's another class of drugs called the immunomodulators, the toxizumab, the JK antibodies, group of drugs that can also block the immune response. So they have had mixed results. There are many studies. They've had mixed results in terms of reducing severity, in terms of reducing mortality. So we are doing our own study on this, comparing tocilizumab with dexamethasone, which has enrolled 11 patients. So that's a pretty interesting study that may or may not show that tocilizumab is going to be as good as dexamethasone. The good thing about dexamethasone is it's really cheap. And so, yeah, it's really revolutionized treatment, I would say.
Thank you, Prof. Okay, maybe I just add 2 more questions. First, where did we as Malaysia go wrong? Our cases used to be very low, suddenly it spiked up. Second, why is the cases still not slowing down despite the lockdown imposed at least in Klang Valley area?
Yeah. So why did we get this surge? So it started off with a detention center in Sabah, right? And then, you know, the rest is history in terms of the elections and all that. But it also, I think, because of the geography of Sabah and the how would I say, the healthcare system in Sabah is not as good as in Peninsular Malaysia. So contact tracing, testing and all that is doubly difficult, especially outside Kota Kinabalu. So if you don't test and get the results quickly and quarantine and contact trace, the ability to spread becomes very quick, and that's what we are seeing in Sabah. Now, why have we not managed to reduce the numbers in even with the lockdown? So the lockdown, I think, first happened in Sabah, and I've just explained because of the geography and the less public health system there. There's always going to be a lag time, right, in terms of the effectiveness of these lockdown measures. So it will take some time before the numbers start coming down again. Yeah.
All right, thank you, Prof.
Hello, Dato.
Hi.
My name is Nizam from Bank Islam. I have a question on the number of recovery. I think perhaps we are looking too much on the new cases, but at the same time, the way I see it, the number of recovery also quite decent anyway. So is it wrong to focus too much on the new cases, but we sort of left out in terms of the number of recovery?
Yeah. So that's a very good question. Actually, I kind of don't have access to the data, but my first question would be, what is the definition of recovery? And you've picked up a very important point, because as I said, the majority of patients have mild disease, right? In Malaysia, we actually admit every single person who tests positive to an acute care hospital for 10 days. So does this recovery mean that is it once those people are discharged? So, you know, if they were not that sick in the first place, it's, you know, one can argue what are they recovering from, you know? So So really, if we only to look at the subsets of patients who got really ill, then the recovery is whether they have no symptoms to start off with or they were already quite sick. I would say that our recovery rate is extremely good. The mortality rate, I'll show you. Maybe I'll show you again those figures. So the mortality rate, 0.7% is world class, right? Now, without meaning any disrespect to people in Sabah, but if you take out Sabah, our mortality rate is going to be even smaller. Now, the mortality rate is higher in Sabah for many reasons. One, as I've already shared with you many times, because of the rural areas, access to healthcare. When they had lots of numbers, the system was partially overwhelmed, particularly in the smaller hospitals. And then also, so Sabah deaths are much higher than Peninsular Malaysia. So I think the recovery rate, I would say that many of them would recover anyway. So the important number to look at is this this mortality rate, and with that we are doing extremely well. So as I said, I'm not trying to diminish the importance of this disease at all. I'm an infectious disease physician. We've got I can't remember now, I think about 30 or so patients in the ward with COVID at the moment, but the majority of them are well. And going back to the need for lockdown is always not the only reason, is to ensure that the health systems can cope. But right now, the Malaysian health system, I think, is able to cope quite well if we've only got 86 patients overall in intensive care all over the hospital, all over the country, and 31 needing ventilators.
Dato, Shadida here from AmInvestment. I was just wondering if you could give us some, enlighten us a bit on this fact about mutation. We have heard the Director General of Health saying that since the beginning, we have seen a few mutations of the virus. So how does this affect the vaccine that is being designed for this virus? Would you need to create another vaccine when the virus has mutated, or is it still largely effective to use it?
Good question. So most viruses mutate all the time, right? And that has certainly been the challenge with the HIV vaccine. And to some extent, the flu vaccine, how they have to make these changes to the flu vaccine every year based on what's called the antigenic shift and drift. So far, the mutation in the coronavirus, I think, has not impacted vaccine design greatly, as far based on my own understanding and reading.
Okay, thank you.
Dato, Suhaimi from SOCSO, yeah? Yeah, just curious, how credible are the data that we are getting on the number of cases from the different sources that we can view on the website? I guess it's a function of how many testings are being done. Therefore, the number of cases will rise according to the number of testing. In your opinion, can we trust these numbers? And is there any suggestion that these numbers could be underestimated? Maybe a case in point is China. China has been reporting a very low number. Whether there is a credibility issue in terms of Chinese numbers. I guess the other question is there any climatic differences between cases in Asia, for example, versus Europe or versus US?
Yeah.
Yeah.
Yeah, I took out the slide that that explains the climatic difference. But first of all, let me address the question about data. Are you asking about globally or specifically for Malaysia?
Globally.
Globally. Yeah, so yeah, it would be based on how many people you test. I mean, I think the classic example would have been Indonesia when they said they had no COVID, and then when the test was more widespread, they found lots of COVID. So yeah, it would depend on how widespread testing is done, and there are websites that track, the percentage of testing versus population and things like that. And Vietnam is one of the best in the world in terms of number of tests conducted per patient per population. And one of the ways they've managed to kind of contain the pandemic there. Same with South Korea and Taiwan. For Malaysia, I think you can very much trust the data. The only caveat that I say there is if you suddenly hear that today we have 1,500 cases, it doesn't mean that all the cases were from yesterday, right? Because some of the tests may have been done even up to a week ago. So it's not from the date of infection and not even from the date when the testing was done, but from when on the person, but from when the test results became available. So, if they're batching the tests and suddenly doing, let's say, a big batch from Tawau today, but the tests were done a week ago, then you might see a big sudden spike. It doesn't mean that we all suddenly need to go, oh my God. Right. So those are the things that that need to be taken into account when you talk about the epidemiology. And the other is, I think there's some important matrices that we need to look into when deciding things like closing schools and closing borders, and it has to go back to the density of the population and the change. So most people would look at per 100,000 population and the changes that's occurring within the last, say, week to 14 days. Not just the absolute number, and certainly not the cumulative numbers alone.
Hi, Dato.
Hi.
Hi. All right. This is Shaidi from EPF. All right. Despite the number of recovery cases increase in Malaysia and worldwide, however, based on what we know from similar viruses, some reinfections are expected. In fact, cases of reinfections with COVID-19 have been reported, but it's still rare. So my questions are, how severe are cases of reinfection? And secondly, who might be at higher risk for reinfection?
Actually, yes, there have been reported cases of reinfection, but that would appear to be less of a concern now. And what is more, in terms of management, what seems to be more problematic is this long-term complication of COVID, known as long COVID. These are in people who develop moderately severe disease and seems to have prolonged fatigue. Some people have terrible insomnia, aches and pains, arthritis. So yeah, whilst we've managed to bring down the mortality of this disease and we have good treatment, I think we still don't want to go the Swedish way and say, look, let everybody get infected, because of these long-term complications that can happen. sorry, I forgot to answer the question on climate, which is also very, very interesting. It would appear that you know, the transmission occurs just as well or just as badly in temperate areas versus hot climates. But what we have as an advantage is, you know, the sunlight can reduce the sort of the longevity of the virus, the viability of the virus. And sunlight also plays an important role in terms of we getting vitamin D, which has been shown to perhaps be protective. And the humidity also plays a role. There was a study reported from Singapore yesterday where perhaps the humidity may carry the virus a bit further compared to dry air. So I think climate plays a very, very important role, and we need to understand this better and either take advantage of it in terms of the sunlight, you know, giving us more vitamin D, be out there. It's protective, and you know, the virus doesn't survive as well. But when you look at it in terms of in you know, comparing whether we don't have to worry because we live in a hot area, I don't think that's correct either, because you've got places like India and Indonesia and all that you know, it still have tons and tons of lots and lots of people with infection. So it's there are advantages, but it's not complete advantage. Yeah.
Dato, I'm Lai here from Bursa Malaysia.
Hi.
Yes, I have two questions. May I know what are the long-term severe impacts or complications to patients who had contracted and then recover from COVID-19, especially in terms of immunity and resistance, as well as the organ failures? And are there one of the main reasons why we should all take extra precautions to prevent catching COVID-19 in the first place?
Yeah, so like I said before, and this is something that's just emerging in terms of patients reporting this so-called, it's been given a syndrome called long COVID. And there's a whole long list of symptoms that patients complain of. It's prolonged fatigue. Some people have terrible insomnia. They describe this thing called brain fog. They continue to have shortness of breath. Not everyone has those symptoms, but these are some of the things that have been described. And certainly in terms of the science behind it, but what in terms of the immune response or the destruction to the immune response or otherwise, all that is still being studied and understood. This is very, very recent. I mean, the Chinese didn't really describe this very much, and not even the Italians. So this syndrome has only just emerged in the last, I would say, 4 months or so. That, you know, when patients, particularly from the UK and US, started describing it. So now there's people looking into this in more detail. And yes, for that very reason, I think we want to avoid, as far as we can, getting infected. I've sort of been speaking with my colleague, Dr. Suresh at Sungai Buloh, about this long COVID and long-term complications, because they've seen the bulk of the patients. We only saw about 150 patients or so, and most of our patients were in the mild to asymptomatic category. So we're going to do a phone survey of Malaysian patients who have had COVID to see if they have these long-term complications or not.
Thanks, Dato.
Hi, Professor. This is Azhar from Bursa.
Hi.
Just hi. Basically, you mentioned earlier on how only There are now 5 candidates. That's at the most advanced stage. And obviously, if you look at the Western press and Western media, a lot of the attention has been given to the likes of Pfizer and Moderna and what have you. I'm just wondering, the 1 or 2 candidates that are coming in from China, from my personal experience, for example, having looked after pharmaceutical companies, whenever they want to get stuff cleared by FDA, compared to some of the other jurisdictions, I've always found that it takes longer for the FDA. So my question really is, obviously the FDA is putting this on high priority and it's very important. I understand that. But given the 1 or 2 candidates that are coming from China, is there a chance that these might be cleared faster? I mean, could you give us a bit of color on that?
Yeah, so there are 2, I think, front runners from China. One is from Sinopharm, which is kind of Chinese ministry. I mean, it's you know, a public institution, whereas the Sinovac, if I'm not mistaken, is a private institution. So those 2 are the front runner vaccines coming from this side of the world. Whether FDA, I mean, you know, there are all those US Sino politics come into play as well, but whether FDA will approve this or not, I don't know. But I think these companies are doing large-scale trials as well, not just in China. And you know, there's another, I mean, there's WHO, and there's a consortium that's looking into all these vaccine approvals. Then, of course, the Europeans as well have a regulatory body other than FDA, if you want to take the politics out of it. So FDA is not the only regulatory body. FDA, of course, exists to regulate for the US, but because of the high standards they used to maintain, or hopefully they still maintain, the rest of the world looks up to it, right? But you know, the Europeans have their own mechanism that if I think the clinical trials, the preclinical trials, and all that are well done, then any major national and international regulatory body, you know, if Malaysia was to rely on it, should be okay. There's, you know, WHO, of course, also plays an important role in all of this as well.
Thank you.
Hi, Dato, Professor. I have one question from the audience. Is there any scientific evidence that shows that the virus can be transmitted via food, especially takeouts or takeaway, when, say, for instance, the people who prepared the food is actually infected?
Yeah. So, okay, so if the person who's preparing the food is infected and coughs all over the food, the moment you fry your fried rice or whatever, then the virus is going to be deactivated, right? That's number one. And if the person coughs onto salad, for instance, where you're not cooking it, the important route of transmission is more the nasal passages rather than, you know, sort of you swallowing it. So the likelihood of this happening is very, very unlikely, and the virus doesn't sort of most viruses don't kind of last outside the human body very long. Those things that I showed you, you know, how it stays on the surface and all that, that is in experimental conditions. So if, let's say, you know, if I cough onto my office table now, the likelihood of it going to be the virus on it is still going to be infected, say, going to cause an infection, say, you know, 3 hours from now when somebody comes, is going to be pretty small. Nonetheless, we tell you to keep your surfaces clean, to wash your hands, to, you know, not touch your face. I think the more that we learn about this virus, the more we know that the most efficient way of transmitting is still airborne and droplets. And hence the, you know, the need to mask and distance and wash your hands.
Hi, Doctor. This is Lillian from East Spring. I was wondering, in the Pfizer vaccine news recently, it indicated that the vaccine needed to be stored below 70 degrees Celsius.
Mm-hmm.
Could you explain why certain vaccines needed to be at such low temperatures?
Yeah, so yeah, I'm not a great vaccinologist, but it's to keep the viability of the active ingredient. Yeah, because if you know, if it's at higher temperature, then the active agent will not be able to induce the desired immune response when you inject it into the person, because, you know, the cells will break down, and it's no longer going to be effective.
But most vaccines do not need this sort of level of temperature, right? I believe it's not as cold.
Some need -20. So you know, so -20 is like a normal fridge. So -70 is like freezer. So yeah, there are many vaccines that also still need the -20. So it depends on the vehicle that the vaccine is carried in, not physical vehicle, but, you know, whether it's a bacteria that is carrying the deactivated DNA, or in this case an RNA, or the protein itself. So to keep those cells intact, you need those different temperatures. Yeah.
Hi, Doctor. Lai here again from Bursa Malaysia.
Hi.
Since we are touching on the subject of the vaccines, how promising are we for the world to have the safe and effective COVID-19 vaccines, maybe by end of this year, or even first Q, or even end of the following year?
So end of this, sorry, go on.
Are we optimistic?
So end of this year, we only have 6 more weeks. So the answer is no, we will not be able to get it. Maybe you know, Pfizer will allow a few people to have it under special compensation, but the rest of the world will not be getting this vaccine by the end of the year. And maybe not even, you know, mid of next year, or I think the soonest I've heard people say that a vaccine will be available to a larger proportion of people outside the clinical trials is what the Americans term as fall of 2021. I think that was what I heard Dr. Fauci saying.
Okay, thanks.
But definitely not by the end of this year.
Dato, Shadida here. I was wondering if you could help me understand, correct me if I'm wrong, but the SARS epidemic that we had, SARS does come from the same family, right, as this COVID. At one time, it was very intense, and we were told that that was airborne, very much airborne. So the infectivity is definitely much higher. But how was it that we were able to arrest that, and we have not been able to arrest COVID-19? Was there any comparison made, and what was the lesson learned from SARS?
Very good question, Shaida. Yeah, so firstly, SARS. Actually, we in Malaysia were very, very lucky with SARS. We had, compared to Singapore, compared to Hong Kong, compared to Toronto, we had very few cases, if you recall. They from the same family of virus, and how it has suddenly disappeared. SARS also caused actually a higher mortality in the people it infected, and was less infectious in some ways. It was a droplet transmission. It wasn't, I don't think SARS was really classified as airborne or aerosol. It was also mostly droplet. Yeah, but and that's the same with MERS-CoV virus, right? It comes and goes. Yeah, but I think the other thing about this COVID-19 SARS coronavirus 2 and how it's really exploded is, apart from its infectivity, is this 40% of people who can carry the virus without knowing that they have the virus, even though the rate of transmission is, like I showed earlier, is relatively low, but nonetheless, there are a lot of people walking around, if you've got already large community spread, that can then spread to other people. I think that's the major difference as well. The asymptomatic carriage. Yeah.
Dato, just to follow up on that question, you mentioned a few times just now that the fatality rate for COVID-19 is actually quite small. With the exception of some of the countries like Italy and all that, where you have a higher demographic of the older generation.
Population.
But yeah, so that's unique in that sense. But if you look at the common flu and other types of infection that we have worldwide, there are also quite a number of deaths a year, even the normal flu, right? Although not to the level that we're seeing in COVID at the moment, not as intense. But do you think that COVID, this might not be the right word, but the hype of COVID is because it's just been so intensely tracked in terms of the numbers, and it's reported, unlike the other, common cold or other thing which have not been reported worldwide. So, given that people can catch it like a cold but may not even know it, could it be that?
Yeah, I know what you're getting at. Yeah, I know what you're getting at. Yes and no, and I think because if we don't try and contain this as best as we can, that it can truly overwhelm the health systems. We saw that in New York, we saw that in Italy, we saw that everywhere where if you just let go, that it can really overwhelm the health system. So there needs to be a balance between the response, and in many ways, I think because we now have good treatment available, I hear what you're saying, that the hype should be toned down, and I must say that I agree with you. I think the heightened fear that's been put onto COVID which is natural when you're dealing with a new unknown virus that did cause a lot of deaths in all those early places, is natural. We saw that with HIV back in the 80s. But now that we know much more about the virus, about the disease, I think we should be able to manage this pandemic a lot more sensibly, to be honest, than what we might be doing right now. There needs to be continued vigilance, no doubt, and all of us need to play a role in terms of those things that I listed right at the end, like internalize ourselves, like, am I putting myself at risk? Am I putting my grandma at risk if I take her to, a birthday party with 50 people or something like that? So to get, but the trick is to get every Malaysian to that level of awareness is not going to be so easy. But the harsh kind of, now, if all of you are not going to behave, now all of you are going to stay home, is also probably not the way to go, because you all are bankers and remisers and what have you. You know that the impact on the economy, except for Bursa Malaysia, is pretty severe, right?
Yes. Thank you, Dato. Okay, I think we have time for another one or two more questions. Any questions from the floor?
So hi, me again from SOSO. I've read an article about a study done by KKM. The infected patients were found to have lower antibody after a few months. Does that imply that whatever vaccine that we are getting, we might have to vaccinate ourselves more regularly than any other viruses that we have dealt with?
So we only know, we've only known about COVID now at best 10, 11 months. There is still, whilst there's a lot that we know, when you think of the thousands and thousands of research and publications that have come out just in a relatively short space of time, it's been quite amazing. But at the same time, understanding natural immunity. For instance, there was a question before about, the risk of reinfection and how long, if you've been infected, will your immune system protect you for? That's going to take time in terms of, we've only now at 11 months. So most of the studies are going to come out of the US, it's where, and Europe, I suppose. So they had their epidemic in March, April, and so there's always going to be a lag time before you know the pattern of the immunity and how effective the antibody response is from natural immunity. From vaccine immunity, that will have to come out from all these large studies. So that's the big $64 million question is, yes, this Pfizer vaccine, 90% of people did produce antibodies and did get protected from infection, but how well and how long is this going to last for? We will have to wait and see.
Dato, there's one question from the chat room. To what extent should testing be done when there are positive cases? Is isolation of persons in close contacts and sanitation sufficient? I think it's referring to the policy at the moment, where if somebody is a positive case and you're immediate contact, you have to be quarantined and you'll be tested. But the family of these people need not be quarantined as well. So do you think that's sufficient?
Yeah. So the immediate people who need to be contacted are defined as close contacts, and that is defined as being with the primary person for at least 15 minutes. If you were in a distance of less than 1 meter. So that's the definition of a close contact. However, that's a very strict definition, but let's say you are in this small room that I'm in, you may be away more than a meter, but you were in the room with someone who's infected for 3 hours. And because it's an air-conditioned and closed room, you would still be defined as being close contact, even though you're not 1 meter. That strict definition is less than 1 meter. So that's the close contacts who should definitely be tested and be quarantined for 14 days. Whether the secondary or tertiary contacts should be tested, I think it's not a bad idea for the secondary and tertiary, or secondary especially, the household contacts of the close contact to be quarantined until you get the result of the first contact, in which case you will be close contact. Am I making sense?
Yes,
right.
Following.
Yeah, so that's why it's very the turnaround time for the test is very important. So if there's delay, you do your test today, you don't know for another 7 days. That's when the cases can multiply because people are not quarantining themselves and going out to infect other people.
Thank you, Dato.
Hi,
Dato, we are.
Hi, Dato. This is Carol here. Just want to ask about in a factory scenario where there are a lot of workers who live in dorms and all that. So if let's say there's somebody infected in a factory and say it's factory A, and there are other factories that factory workers that factory A
share
workers live together. Yeah, share. Yeah. So to what extent does testing have to go?
Yeah, so the dormitory situation, the migrant worker situation is where we need to put focus on, as well as detention centers and prisons, because that's where we know, as has been the Singapore experience, where transmission risk is high. So if a factory worker comes from a dormitory that has, if a factory worker has an infection, he comes and he lives in a dormitory of, say, 15, 20 people, then all of those 15 to 20 people will need to be tested for sure. Because as you alluded to, they live in crowded places where it's, the hygiene is also not optimum. But does it mean that the factory needs to be shut? No. No. Okay, there is a tendency to react by closing down malls, closing down offices, which is not necessary, right? You keep the infected person away. I mean, if I use the analogy of the hospital, we are getting patients, and occasionally we are getting our own healthcare workers, nurses, particularly, or people working in the services who become infected because PPUM sits in the red hot zone, right? So we have a system where we very, very thoroughly contact trace our healthcare workers and keep them away from work. But we don't close the hospital. If we do that, then you all won't have any hospitals to go to, right? So, but by the same token, it's not necessary for the whole factory to be shut down, and it's not even necessary. I don't know where this kind of massive decontamination came from, because really it's the surfaces that needs to be clean. You don't have to kind of spray paint the whole building. So some of the practices that we're doing can probably be, now that we know more about the virus can probably be re-examined. I read an interview with Dr. Ashish Jha, who's a public health expert who is now the Dean of Brown University and was formerly at Harvard. And he calls this whole measuring temperature before you go into a building as theater hygiene. And he's right, because, not everyone has a temperature, particularly not at that, it doesn't mean that you don't have a temperature, you're not infected. So certain things like that, yeah.
Thank you.
With migrant workers, I think the most important thing is education to the migrant workers in language that they understand. And secondly, to have a system in place where they are not afraid to report symptoms to their supervisors. Every industry and company needs to have like an OSH, where people can go to and be tested, come forward if they have symptoms. One can argue doing periodic testing of these migrant workers, but I think money would be better spent in ensuring that the places they live in are conducive and has low risk for transmission. Because we're going to have to do this long haul.
Thank you, Dato. Dato, we hope we are not holding you back from anything important, because we have done quite a long Q&A here.
Right.
Thank you very much.
Yeah, I think I'm 5 minutes late for a UNH meeting, but it's okay. Yeah.
Okay, I apologize.
That's okay.
If there's no more questions, is there any more questions from the floor? Otherwise, I want to conclude with one. I hope you can just reiterate a point that you made to us earlier on, because for us, the investors, this is probably the most important point to know. You mentioned that you expect commercial production of the vaccine that we're hearing about and all that at the earliest in the fall of next year, is it? The third quarter?
I think that's I think that's what I've heard from the vaccine experts. Yeah, but with vaccines, anything can happen, and it's unprecedented actually to have a virus and then vaccine development and then commercialization in under 2 years. I mean, most vaccines take years and years and years. And what has managed to help people jumpstart the vaccine is, I think, because of the in some ways the preparedness and people using existing technology to jumpstart, but still, doing the phase 2 and 3 trials in particular, where you have to test this vaccine in tens of thousands of people. Whatever you do is going to take time, and I think you don't want to compromise on the safety. You don't want to have a repeat of say the Sanofi dengue vaccine, for instance. So I think whilst you want a vaccine as quickly as possible, but there cannot be shortcuts to safety. That's my view. Mm-hmm.
All right. Dato, Professor Dr. Adeeba, I would like to thank you for sharing all your knowledge and experience with us today. I find it has been very, very useful. I hope that we can have another session sometime next year when the vaccine is on.
Sure. Or a bit of advertisement here, or you could all sign up to the conference, to the COVID-19 conference. We hopefully will get an all-star a presentation from the likes of Fauci and Gabriel Lung from Hong Kong and the experts on ventilation and things like that. It's going to be in January. Yeah.
Okay.
Okay.
Sure.
All
so
right.
thank you very
Thanks.
much.
Bye.
Thank you.
Thank
Thank you.
Thank you.